Meet Dipashant, a 12-year-old boy living in India. Recently, he has been struggling to go about his normal daily activities, experiencing muscle weakness, frequent falls, and struggles to stand back up. His mother, Aditi, is incredibly concerned, as her brother experienced similar symptoms before his premature death in their youth.
Dipashan's blood tests show significantly elevated levels of creatine kinase, and considering the loss in muscle mass we believe your son has DMD, which is Duchenne's muscular dystrophy.
But what is Duchenne's muscular dystrophy? How did Dr. Sang-Hyun Lee conclude this outcome? And will Dipashant ever recover?
Duchenne's muscular dystrophy, or DMD for short, is an X-linked recessive disease that typically manifests during early childhood, including symptoms of proximal muscle weakness and calf hypertrophy. This weakness progressively worsens, with loss of ambulation by early adolescence. Resultantly, it must be closely monitored and managed due to the possibility for complications such as restrictive lung disease and cardiomyopathy. So, DMD is an X-linked disease, so get rid of this. And it's recessive. So, for both types of X alleles, it's going to have the little d in order for our patient to be affected. And since it's recessive, if a patient has a big D, they're not going to have our disease. But how has Dipashant got the disease if neither of his parents have it? To explain this, we'll walk through a family pedigree. Since he has the disease, Dipashant must have the X little d allele, and with the Y chromosome. Since he's a male, he must have inherited this Y chromosome from his father. And his father is unaffected with the X big D allele. Therefore, the only way Dipashant could have inherited the disease is from his mother being a carrier with the X little d allele, and since he's unaffected, X big D allele. Now we'll consider his uncle, who, since he also has the disease and unfortunately passed away, has the exact same genotype as Dipashant. For Dipashant's uncle to have inherited such a genotype, again, we must have a very similar pattern, where Dipashant's grandmother has the X little d allele and the X big D allele being unaffected, and his grandfather also being unaffected, X big D allele and with a Y chromosome. It now makes sense why Dipashant has inherited DMD despite neither of his parents having it, and why the disease is so much more common in males than females. For a female to have DMD, she would need 2 copies of the recessive allele, whereas a male only needs 1. So, we've covered how Dipashant has acquired DMD, but let's now look into why he's experiencing these specific symptoms.
DMD results from frameshift mutations in the dystrophin gene. This causes the shortening of a dystrophin protein. These frameshift mutations can be caused by nonsense mutations, which are caused by the production of premature stop codon. However, they can also be caused due to exon skipping. Mutations that can also affect the dystrophin protein include the removal of necessary exons. This causes a shortened dystrophin, which causes a more benign form of DMD.
Here we have a regular dystrophin protein, which is able to perform its function correctly. Here we find a partially shortened dystrophin protein, which results in a more benign form of DMD. And this is a fully shortened form of the dystrophin protein, which results in the more acute form of DMD.
The dystrophin protein anchors the extracellular matrix to actin filaments within the cell. Due to the shortening of the dystrophin protein, the sarcolemma is broken apart. This allows for the movement of calcium ions into the cell, which activates calcium-activated proteases, resulting in breakdown of the cell. Creatine kinase also escapes the cell. This is detectable in blood tests and prevents the phosphorylation of creatine to form creatine phosphate, thus resulting in muscle fatigue. As the individual ages, their ability to replace the cells broken down decreases, and this increases the amount of fatty scar tissue formed.
So I'll speed run through the stages. There are 5 different stages of Duchenne's. The first stage is the diagnostic phase, where condition is identified, like this, and the symptoms emerge. Stage 2 is the quiescent phase, where symptoms start to develop, and patients can become noticeably weaker than their peers. Stage 3 is the loss of ambulation. Patients often need assistance to walk or stand properly, as the quadriceps weaken. Stage 4 is when spinal deformity develops. It's when the weakness in trunk muscles lead to spinal deformity and pulmonary difficulty. Our last stage, stage 5, is when complete dependence on assistance is observed and respiratory insufficiency develops, eventually leading to death.
The gold standard treatment for Duchenne's muscular dystrophy throughout childhood is steroids. No, not those steroids, but these steroids, glucocorticosteroids, which are potent anti-inflammatory agents, such as this one, prednisone, or the more common gold standard treatment, deflazacort. Both reduce inflammation in the sarcolemma and therefore help prolong ambulation and reduce the symptoms of Duchenne's, specifically in muscles of the leg, but also in the diaphragm. Now, the problem with glucocorticoids is that they are potent osteotoxins, that is, bone toxins. They enhance the activity of cells called osteoclasts that eat away at your bone to liberate calcium, which makes them very porous and very brittle, which, as you can imagine, is a very awful combination. Yep, awful. Speaking of which, cardiac Duchenne fatality typically presents with either a heart failure or a cardiac arrhythmia due to degradation of the myocardium, or the muscle layer, in the heart. Regular cardiac imaging is needed, although it will have to be MRI, so I can get rid of these. Now, there are no specific drugs for Duchenne's. However, aldosterone or beta blockers cannot be used to reduce blood pressure and therefore strain on the heart. Respiratory failure is a major cause of morbidity in Duchenne's and comes along with complications such as lung collapse, pneumonia, and mucus blocking of the airways. Typically, a child's forced vital capacity, actually can breathe forcibly, is correlated with what it should be given their age and size. When this drops below 60% or 50%, mechanical devices known as mechanical exsufflation devices are used to ventilate the lungs forcibly, and this is a dramatic increases in life expectancy.
In terms of actually curing Duchenne's muscular dystrophy, the frontier of science lies with gene therapy.
And how did that make you feel?
One pathway of gene therapy is involving exon skipping, which is where exons are literally skipped by DNA. This causes the formation of a functional gene.
There are two currently on the market gene therapies, eteplirsen and atulurian, both of which are very expensive and have not been proven effective. But this is definitely the way to go in terms of curing the disease. Now, Duchenne's is ultimately and unfortunately a fatal condition. However, as can be seen by this chart on screen, life expectancy prognosis has been increasing year on year, and hopefully with gene therapies on the horizon, we may even have a cure for this condition in the future.
And I'll see you in the next